Uh, Good afternoon, all. The title of my presentation today is Cracking the Cracked Tooth Code, and I'll start with the video of a patient explaining his symptoms and then we will follow his history.
मेरे को 6-7 महीने से इतनी सेंसिटिव थी कि नीचे वाले जबड़े में मेरे को पानी ठंडा और गर्म पानी लगता था। मैं बहुत परेशान हो गया। मैं फिर डॉक्टर साहब के पास चेक कराने के लिए गया तो मैं डॉक्टर साहब को बोला, सर मेरे नीचे वाले जबड़े में बहुत दर्द हो रहा है। रात में मेरे को दर्द और बढ़ने लगा। मैं रात में जबड़े को पकड़ के बैठा ही रहा। रात भर सो नहीं पाता था और मेरे को आराम नहीं मिला।
So the patient actually initially went to a dentist with a history of sharp intermittent pain of moderate intensity over his left facial region, which lasted seconds to minutes. He was unable to localize the pain to any of the tooth. The pain increased while biting or eating and was occasionally sensitive to cold food items. The dentist examined the patient clinically and found no cavities, no gum disease, good oral hygiene, except for the presence of occlusal via facets, indicating a habit of occlusal grinding or high biting forces. The angulated 2D radiographs were taken by the dentist, which revealed that there is no hidden caries present there, there is no bony lesion, the adjacent bone health was normal, and no visible fractures or cracks were found. The patient was diagnosed as having hypersensitive dentine and he was prescribed anti-sensitive toothpaste and night guard for wearing at night. The patient didn't find any relief after 2 to 3 weeks and hence was provisionally diagnosed as non-odontogenic neuropathic pain and was prescribed tegretol, that is carbamazepine, pregabalin and nortriptyline, and was referred to a neurologist. There the patient was diagnosed as having a atypical facial pain. Since the dental cause was already excluded there, the patient also gave the history of headache since last 10 or 12 years, and the patient was prescribed amitriptyline and was asked to sought an ENT opinion. The ENT guy gave clearance and then the patient was referred to the psychiatry department. Hence a vicious cycle continued and the patient moved from one dentist to other neurologists, to psychiatrists, and ultimately landed to CDR, where after careful examination, a diagnosis of a cracked tooth was considered. Now this slide depicts the contents of our subsequent talk for the day. What is a cracked tooth? What is its incidence, etiology, and how we diagnose that case and manage that case is the subsequent talk for the day. Now, cracked tooth has been classified under longitudinal tooth fractures since it has a direction component. The crack or the fracture is along the long axis, and again it has also a time component. The crack propagates over a period of time. Rest all the longitudinal tooth fractures which we can see here, fractured cusp, split tooth, they are complete fractures, while cracked tooth is an incomplete fracture. And the complete fractures are relatively easy to diagnose, while the cracked tooth, which are incomplete fractures, they are very difficult to diagnose. They are a challenge to diagnose, and they can be defined as a cracked tooth is defined as an incomplete fracture which extends from the crown and it goes subgingivally, that is beneath the gingiva, and it's usually directed in the mesodistal direction. Now, it was earlier called as a cracked tooth syndrome. Now, what is a syndrome? You have to understand that. Syndrome is basically a set of symptoms and signs which are highly correlated with each other and they are associated with a particular disease. But here, syndrome is not a proper terminology for a cracked tooth because the signs and symptoms, they are not correlated to each other. Sometimes one sign and symptom is present, sometimes the other sign is symptom, and they are not always associated with the same disease. So, the term syndrome was removed from that only. Now, the present terminology is a cracked tooth. Now let's come to the a classification that we have gone for the classification. We have discussed about the definition. Now let's come to the incidence of the cracked tooth. The incidence of a cracked tooth is said to be around 8 to 15%, and it has been reported to increase during the last decade. Almost all the studies have reported it to occur after 40s, with its peak in the 4th and the 5th decade. The reason attributed is due to the decrease in the elasticity of the dentine due to the aging, which makes it brittle, and the loss of the enamel due to attrition, and which the enamel actually acts as a compression dome over the dentine and it prevents any crack propagation. The demographic data suggests equal distribution between males and females. However, few studies refute this, and in fact, as far as our unpublished data, we have found more in male patients. Tooth-wise, it is mostly seen in mandibular second molar unanimously. This is followed by maxillary molars, maxillary premolars, and mandibular first molar, and not necessarily in that order. Population-based differences are present in the order of tooth involvement. For example, in Koreans, it is reported that it is more frequent in maxillary molars. Why? They are given a reason. They say their mandibular molars are inclined, and hence the wedging effect is seen over the maxillary molars, and hence it is mostly seen in maxillary molars. Now, the reason for a molar involvement can actually be explained by this video, small animated video. It is called as a nutcracker phenomenon. There is an increase in the biting force as one moves towards the fulcrum of the mandible, that is TMJ, and the bite force reported in the molars is said to be around 4 times that of anteriors and twice that of the premolars. So, let's see what is the etiology of this entity. It can be because of basically 2 reasons: normal physiological forces when applied to a weakened tooth, or number 2, when the forces are excessive but they are applied to a healthy tooth. The first case, where the forces are normal and the tooth is weakened, is typically seen when a large filling or a large restoration is present in the mouth with less remaining tooth structure, or when a large decay is present underneath the filling. In that case, a normal bite force can also lead to a crack initiation. It is mostly seen in case of silver amalgam filling, because amalgam was known to expand, and actually it was considered a good property because it leads to sealing. But since it expanded, it put forces on the tooth, and it led to the crack initiation, though the incidence was very less at that time. However, interestingly, the incidence of crack is increasing in unrestored tooth nowadays, which may be due to the second scenario, that is excessive forces on a healthy tooth. The study here, it shows the 60% of the teeth with cracks were unrestored, while those in which the amalgam filling was present, only 15% of the cases showed cracked teeth. So let's see what our evidence is there. We have our own evidence on cracked tooth, and we followed the cracked tooth for 8 years, and we found that it's in line with the existing medical literature. Except the gender except the gender distribution, we have seen more in, as you can see, we have seen more in male patients. Around 80% of our patients were male in which the cracked teeth were seen. The age group was same. It was 50% of the cases were seen in around 45 to 50 year age group, and again 50% of the cases were seen in the mandibular second molar. Now, the pandemic time is said to be associated with an increased rate of cracked teeth. This was a study published by an American group, and they found that the incidence increased by 20% during those 2 years. They attributed it obviously because of the increased anxiety and increased stress, which led to tooth grinding and clenching. The same was our observation actually also, and we found an increase in the incidence of cracked teeth significantly during that time period. The most common reason for cracked teeth in an unrestored tooth is said to be a bruxism or lateral grinding or clenching of the teeth consciously or subconsciously during sleep. This resulted in eccentric forces over the teeth leading to crack initiation. The tooth normally they are very well resistant. They respond very well to compressive forces. Only the tensile forces are the forces which creates problem. And bruxism leads to those kind of forces, eccentric forces, and that is said to be the main cause. Then next cause in an acute masticatory accident, when a patient accidentally bites, as you can see in the animation, into a hard object like a stone in food, nuts, unpopped popcorn kernels, or hard candies, or while using teeth as bottle openers. So these masticatory accidents can definitely lead to cracked tooth. Now, we have done a study linking the facial profile with the crack incidence, where we have found that basically there are three types of facial morphology. The euryprosopic, where the facial profile is short and broad; mesoprosopic, one of our PG students, where the facial profile is normal; and leptoprosopic, where the facial profile is long and narrow. And our study found that 70% of the crack teeth is present in europrosopic facial profile. That is when the facial profile is short and broad, and often such patients have very prominent masseter muscle. Other reason could be the presence of malocclusion or abnormal contacts between teeth, which can again lead to eccentric forces. Presence of a prominent and bulky cusp can lead to the wedging effect on the opposing tooth, again leading to the increase in crack propensity. Again, presence of steep cuspal inclines, deep occlusal grooves, they lead to force concentration at the joining point, at the meeting point, again leading to crack initiation. Last region could be the thermal cycling. In oral cavity, the tissues are continuously exposed to extreme temperatures, hot and cold repeatedly, and this can lead to alternate expansion and contraction of the minerals, and over a period of time it can lead to crack. Again, it has also been seen in patients who chew ice cubes. Lastly, chronic fatigue failure, as we see in metals, it is also responsible, can also be responsible for cracked teeth. It can be because of the alternate tension and compression because of continuous biting forces in the tooth. Next, we come to the symptoms. The diagnosis of cracked tooth is the main challenge, actually, as I said, is main challenge, as it was depicted in the first video. Now, why is that so? We have to understand that. Number one, there are three phases of crack development. One is the initiation, propagation, and lastly, manifestation. Now, in the initiation and the propagation stage, the crack cannot be visualized with naked eyes. So, it can only be seen in the manifestation stage. Even there, it is quite challenging to differentiate it from the normal anatomical grooves which are present on the tooth surface. In the first two phases, the pain is erratic, it is diffuse, it is moderate and intermittent in nature. And more importantly, it cannot be localized to the offending tooth, which might not again be tender on percussion. The pain radiates to the orofacial region, most often involving the maxillary and the mandibular divisions of the trigeminal nerve. And again, it has been observed that in most of the cases, the pain is protracted. That means the time period between the diagnosis and the first symptom is around the time period between the first symptom and the actual diagnosis is around 3 to 6 months. Only in later stages the pain becomes localized. The symptoms again depend on the extent of the crack, while the extent depends on the location of the crack. For example, the distal cracks, the cracks which involve the distal marginal ridge, they are said to be deeper and they are considered to have a poor prognosis. Now, the most common symptoms which are related to tooth is commonly said to be the pain on chewing. Now, first for that we have to understand the dental anatomy. Now, the hard tissue of the tooth consists of enamel and dentine, and this dentine contains some channels which are called as dentinal tubules, which are filled with liquids, hydrodynamic liquids, and when those liquids move, they excite the nerve fibers. So chewing results in micro movement of the partially separated dentine, which results in the sudden movement of this dentinal fluid, which I said, and this activates the myelinated A delta fibers. Chewing discomfort, this type of discomfort is actually seen in early stages of the crack, and there is no pulpal inflammation is present at that stage. In later stages, when the crack propagates and it comes near to the pulp, the patient often reports increased sensitivity to the cold, which is normally moderate to severe in nature. This might be the result of a bacterial biofilm which percolates through the crack and initiate the pulp inflammation. In advanced stages, the infected pulp becomes necrotic and the patient again becomes asymptomatic. Let's come to the diagnosis. With the range of symptoms, the diagnosis is actually quite a challenge, at least in the initial stages, when the pain is not localized to any tooth and the pain is referred to the orofacial region. So there is no standardized protocol for diagnosis, but various tests have been recommended, which actually starts from visual inspection with different aids like magnification, transillumination, other surrogate tests like percussion intensity, bite test, dye staining, and radiographs. We'll come to each test one by one. Now, visual inspection should be performed after isolating the tooth with cotton rolls, and this should be followed by cleaning of the tooth surface. Now the soft tissue debris, also we call it materia alba, they can be seen retained in the crack, as we can see in that picture. The arrow is pointing to that. The crack can, again, it is difficult, as I said, it is difficult to differentiate with the normal deep grooves. The crack can be differentiated by the groove, because the crack often involves the proximal marginal ridges, while the groove rarely do so. Dental operating microscope is a good aid in inspection of such cracks. The recommended magnification is said to be around 10x into 40x into 14x. Staining dyes like Kerry's detector dyes should be used to detect the cracks. Methylene blue can also be used. They are applied over a cotton pallet and rubbed over the tooth surface. The excess is washed off and the tooth surface is then visualized. However, sometimes when the crack is inside the pulp chamber, we might have to put the cotton pallet and temperize the tooth for a few days for the crack to be visible. However, this is a disadvantage because the crack might propagate during that time. Again, next come to the percussion test. The tooth is percussed or with a mirror handle from different directions. It is important to individually percuss all the cusp with the back of a mirror handle. Periodontal probing is again very important surrogate test to detect the crack. It has been seen that the crack extending into the root surface have been associated with angular bone loss and resulting in a pocket formation. The pocket is often located in the proximal surfaces. They are often long and narrow, unlike what is seen in the gum diseases. They are wide and shallow in periodontal diseases, while here they are long and narrow. Again, the tooth with more than 6 mm of pocket depth are said to be of poor prognosis and have only 40% success rate over a long period of time. Bite test is again very important. It is done over the suspected tooth with the help of a cotton roll or with the rubber lead of a like cartridge, and the pain is tried to be simulated. More often, the pain is present while biting, as well as while releasing the cotton. It is also called as a rebound phenomenon, and it is typical of a cracked teeth. Aids like transillumination have also been recommended for such diagnosis of cracked tooth. The LED light is placed over the buccal surface or a lingual surface, and the crack, if present, it often blocks the transmission of the light. It is also called as day and night effect, as we can see in the picture. Radiograph examination is normally not helpful since the crack is often present mesiodistally while the X-ray beam are directed buccolingually. It is only useful for excluding other odontogenic causes. However, it can be used to visualize the associated bone loss, which can sometimes be seen during the later stages. Sometimes when the crack is present buccolingually, it can be visible like the one which is seen in the X-ray, but such cases are rarely seen. Next, let's come to the 3D imaging. 3D imaging like a cone beam computed tomography has been initially proposed with a limited field of vision, with a voxel size as small as possible. However, the lowest voxel size which we have normally is around 125 micrometer, and it has been seen the cracks are even smaller than that. So it is very difficult, or in fact impossible, to diagnose the crack. Except we can see the pattern of the bone loss. As I said in the periapical radiograph, the pattern of the bone loss can be better seen in CBCT as it is defected. We can see normally we see angular bone loss in such CBCTs. Next, come to the management part. Management is not a dilemma. It consists of 3 A's, which are ascertain the cause, ascertain the extent of the crack, and then act accordingly. Let's come to ascertaining the cause. We have to ascertain the cause, which can be clenching or a grinding habit of the patient. So hence, we have to prescribe a night guard for the patient. And again, if the patient has the habit of eating hard foods like, as I said, nuts, popcorns, candies, then they should be asked to be very careful. Steep occlusal planes, they has to be smoothened. Any prominent cusp again has to be reshaped, and it has frequently been observed that the patient who has developed a crack, he has a history of crack development, or he will develop a crack in the future. So it is very important to inform the patient in such cases. If the patient again is a brittle nut chewer, like in this case, you have to warn him about the crack, and more important for some other reasons also, and he should be advised to stop the habit. And next is ascertaining the extent of the crack. It is recommended, we say chasing the crack. To ascertain the extent, we recommend it to chase the crack. What do you mean by chase the crack? Chasing the crack means that you can see in the video that we have to drill the crack under anesthesia and to perform it till the crack disappears. We can see here the crack has disappeared now. And once we chase the crack, then we have to act accordingly. Depending upon the situation, if the crack is superficial, it disappears after drilling. Composite restoration is done since it bonds with the tooth and prevent crack propagation. Like in this case, we have seen the crack is seen along the distal marginal ridge. We have applied the dye, we've seen the crack, we chased it, and we have filled it with composite. So the patient is doing good. This is the follow-up of the patient. However, if the crack extends to the pulp chamber, then we have to first encircle the tooth with orthodontic band to immobilize the fragment and to prevent the further progression, as we can see in the pic. The root canal is initiated and care is taken not to remove more than the tooth structure that is necessary. So this is the case. We have done the root canal and we have banded the tooth previously, and then very important to crown the tooth in such cases. Now, if the crack extends below the orifices, the prognosis decreases significantly in such cases. Then we have to think of some alternative treatment, like a root resection, which we have performed here, a hemisection, which we have performed here. That is, remove only that part of the root which has shown the crack. In this case, we have removed the cap, we have given a crown, and the patient is doing good. And in some cases, the cracks extend to the floor of the pulp chamber, then extraction is the only treatment which is recommended for such cases. So let's recapitulate. So what did we learn today? We learned what a crack is, how about the different nomenclatures of the crack, its incidence, its etiology, the symptoms. Diagnosis is quite a challenge, and management, which is not actually a dilemma. So we are nearing the end of the presentation, and want to show another case which came to our center last week. He happens to be a very famous and a respectable former cricketer from Delhi, known for his attacking batting style. He had erratic pain over last 1 month. He was unable to get a diagnosis, and the pain became severe, and ultimately he was referred to our center 1 week ago. On close examination, we can see a crack is visible. We took the CBCT, we performed the CBCT scan, which didn't show the crack as expected, but the bone loss was visible at the apical region. As we can see in the CBCT, the RCT were initiated, which relieved the symptom in few hours. To conclude, when it is very important for the patient as well as a medical professional to be aware of the crack entity, which can actually mimic atypical facial pain or a neuralgia, and early diagnosis is very important for benefit of the patients. And again, we have been taught in medical that when you hear hoof beats, you think of horses and not zebras, but I think in some situations hoof beat means zebras and not horses. Thank you. Any questions? I would be happy to answer.
Sometimes it can be that 15% of the cost of all the dental pay is correct truth, as you say. And the patient had to go to secretary also and the ENG also and that was really nice. I have a couple of questions. One is there any correlation between the causes and the direction of the
Yes, ma'am, it has been seen that the cracked tooth are normally mesodistal in direction. However, the other causes, the other like longitudinal tooth fractures which I described in the plique, like that or vertical root fracture, they are normally in buccolingual direction. So this cracked tooth, they are often in mesodistal direction. There has been no study which has depicted in cracked tooth the cause and the direction of the study, but yes, it would be interesting to definitely it would be interesting to study that.
Structure before manifestation, she can offer that we offer chloride treatments as patients. So, is there any preventive
Ma'am,
thing that can be
preventing mechanism only can give them occlusal night guards. I don't think any filling materials apart from composite can prevent that. Even in fact, some of the literature they says even if you do a composite filling, better give a crown on such patients. Don't leave like that. So most important thing is a full coverage restoration in such cases rather than an intracoronal bonding. Extracoronal coverage is more important in such cases.
maybe for material
Sure, ma'am. Maybe some smart materials which they are now talking about, which can fill that with. Any other questions, anyone?
Thank you, Krishna. That was something very nice as far as the cause and the direction of the crack. So the only information we have up till now is that most of the cracks are distally oriented. So if you have the mesial half of the tooth and the distal half of the tooth, the literature and our experience says that most of them are distally oriented. They've given us a cause for that. There's an article which is very well reflected on why do we get to see more distal cracks. So one thing very sure now is that distal cracks are more seen. They've given us a reason for it. But your point to correlate the direction of the crack with the cause, I don't think so. It's been done. Frankly, what happens is we really never come to know what the cause is. Most of the time it becomes multifactorial. If it is in an acute masticatory accident, the patient, whether he tells us the history or not, betel nut chewing bruxism is most of the times combined with betel nut chewing. And if it is a malocclusion, then, so if you take a hypothetical situation where the patient has malocclusion, is the betel nut chewer and a bruxer. So you really do not know that which one was leading to the crack. But definitely, we do realize that distal cracks are more. As far as your material aspect is concerned, we do have flowable, but you're trying to point out if we have something which can prevent them. It's again that prevention is to, as Siddharth said, that if you find a cracked tooth in a patient, be sure that in a couple of years or a couple of months, he'll crack another one. Now you need to be sure what was the cause for the crack. So most of the times when we've seen is these deep occlusal grooves. So if you see a 45 years, so most of the cracks are in between 45 to 50 or 50 to 55. You open his mouth and see that he has steep cuspal inclines and which hasn't got worn off physiologically with age. And if he's got a cracked tooth, the intelligent thing is to ground or redefine those cusps, decrease the steep cuspal inclines, because most probably those steep cuspal inclines at a 50-55 years was the cause for his. If it's orthodontic malocclusion, we'll have to get that corrected. So somewhere prevention is there related to the diagnosis and trying to find a material which would seal these cracks. I do not know whether we can do that. Maybe something would come up sooner or later. And I must tell you this fact also, that I mean, it all comes out of experience, Krishna. We were not seeing cracked teeth before 2012. It wasn't that we were not aware of this. The literature was there, but the literature was limited. As I would say that even the books, few books would only contribute a chapter towards it. Most of the books would just have a part of the chapter being dedicated to cracked teeth. What we've seen is since 2012, so it's almost a decade. See, cracked teeth where excessive tooth structure has been removed because of fillings or caries is okay, well understood. But in those pristine teeth where there was nothing wrong, and those teeth cracking more now in the last decade is something which is more interesting to see why they are cracking. What we can see is maybe the change in dietary habits of patients, maybe that's contributing. But what the literature and our understanding is bruxism, which is contributing to a higher number of teeth cracking, healthy teeth cracking, is bruxism. They've also attributed it to the same reason, but I talked from 2012. So somewhere in the last decade, there has been an increase in bruxism, and bruxism is known to be a major defined cause of crack teeth. So that's the reason why our department also sees more teeth which are being cracked. We used to extract them immediately, but now somewhere we are trying to see whether we can save them, but it's most of the times extraction for these teeth. But why we bought at the last moment this one was because most of the times patient is roaming about from why the neurology, psychiatry or ENT within our own center it's roaming about. So this particular patient whom Siddharth mentions was I think he was a captain for the Indian team also. We can tell them it was Sehwag. He came in last week and he was already given an LA. I'm not saying anything. He was already given an LA to treat sensitivity and thought that there was a deep periodontal pocket. But so within our center itself, we have a tendency to miss it. So only we thought that maybe at least our colleague from oral surgery would definitely keep this in mind. Yeah, thank you. And you can just go tell everybody. So the bottom line for postgraduate says patient. So most of the time what we do is when the patient comes in with pain and we can't find anything, we just say that he's just dreaming about the pain. I always tell them no patient will come into AIIMS at least walk in 10 kilometers to dream about his pain he's having. So if you see a teeth which is periodontally healthy, which does not have caries, please keep in mind, because our eyes will only see what is known to our mind. If we don't know what's in our mind, then the eyes won't see. So keep cracked tooth as a diagnosis.
So my take home message is involved in this scenario where I don't understand the reason for tooth pain.
Before starting gabapentin. So a lot of patients come down from AAPSE with gabapentin started, and you do realize what the side effects of gabapentin are on somebody's mind. One, he goes, reads on the Google and thinks he's having a neuralgic pain. So half the time an educated patient would be weakened because if he thinks he's a neuralgic pain which has no kind of treatment. So at least if we can tell him, so a lot of patients from oral surgery come to us, started gabapentin, but turns out to be cracked tooth for us. Oh, thank you. And I think you are from which department, please? Yeah, oral surgery. Okay, oral surgery. Yeah. Everybody's new faces. The centers become so big that becomes very difficult to know. I'm sorry for the query, please. It's just that it's expanded so much and everybody's got so busy that it becomes very difficult to meet. So you've come across any cracked tooth before? You have? And could you diagnose it? Okay, good enough. I hope that somewhere you get benefited. and benefit your patients out of it. I think our department now, at least in endo, because Sidzi was very confident when he was telling Sehwag, because the patient also needs to be convinced, and if there is a team of doctors who are looking at it, as it was in Sidzi's case, that there were already 2 doctors who were looking after Sehwag, and they were quite sure that they were dealing with a periodontal pocket. Trying to convince them first that look, we deal with a cracked tooth. Second, first is trying to convince yourself, okay, a VIP patient, I shouldn't be going wrong on my diagnosis. Then trying to convince those 2 doctors, and those doctors who had already given an opinion to Seva that look, probably it's just a periodontal pocket and we're going to clean it and you're going to be relieved of your pain. So I was very happy that we could do that and solve his problem, and I hope in future also that, because now our postgraduates and senior residents are tuned to keep it in their mind. Vishal, am I right? That Archana, I think you guys are tuned to keep cracked tooth, and specifically those round, big, mastocytic faces. And if they're eating, so those big round faced people are ones who take a lot of non-vegetarian diet. So in India, we chew bones also. Yeah. Thank you very much. Thank you. Thank you. Thank you very much, please.